All right, good morning, everybody. Welcome to Syracuse. Thank you for making the trek. Following up on Henrik's great presentation, I'll be diving into a little bit of how did we get to where we are today and what happened in 2024, and then going forward into the future, what do we need to be thinking about? And a lot of this will be through my lens of working as an epidemiologist in dengue for some time, but also in working in local public health and looking at how systems come together or don't come together to really impact the people who struggle most with public health problems like dengue. So Alan Rothman in his great talk this morning already presented this figure, but it showed the expansion of co-circulation of serotypes. First, more concentrated in Asia and Southeast Asia, and then with increasing co-circulation in Latin America with the sequential reintroduction of serotypes, culminating ultimately in this dramatic outbreak in 2024. But as we think about what led to 2024 and what we need to be thinking about for, say, 2075, as we look at the intersection of these three elements of dengue transmission, the humans, the virus, and the vector, for the sake of this talk and in my thinking about what might be impacting the human population through that time, there's movement, connectivity, and inequality. So there's more of us traveling farther than we ever have before, bringing viruses to new places, new genotypes all the time. There's ongoing environmental degradation and urbanization, so concentrating people, putting them in areas where there's poor infrastructure, and also on the fringes of, for example, sylvatic transmission sites. There's the changing epidemiology, including what Henrik just spoke about with the changing demography, and then the consequences of our interventions, which are destined to be imperfect because they all are. They will be leaky, and what does that mean? I'll touch on this briefly, but then with an eye towards 2075. As prior speakers have mentioned, the world is heating up. We're going to see, to some degree, expansion of dengue into new areas. At some point, I don't know if this is good news, there'll be some areas that become so hot and so arid, they won't be strong enough to support dengue transmission any further. But that'll be just a fraction of sites. It's interesting to think about how different some of these modeling predictions are in terms of what the impacts of climate change may be. So the first model shows a somewhat modest increase in new areas, shown in red in terms of new sites for dengue transmission. And they suggest that most of the increased transmission by 2080, I believe it is going to be driven by actually urbanization in areas that are already endemic. But there's very dramatic projections of what may happen in places like Europe. So in this second figure, we're looking at under predictions of moderate approach to climate change on the left and a do-nothing approach to climate change on the right, what we may expect to see for Aedes aegypti and Aedes albopictus. And what we can see is comparing spring to summer and going forward to 2099 in this model, you can see a dramatic expansion of both vectors into Europe, suggesting that they may be quite at risk. As mentioned, the relationships between vector fitness as well as their potential to serve as capable vectors for dengue is not linear. And we can expect to see that at some temperature range, some upper temperature range, they won't become more fit. They won't be able to transmit more. And it varies to some degree. But for example, the adult lifespan, the adults live for shorter periods above approximately 35 degrees Celsius. They're less able to create offspring for their eggs to survive above around 35 degrees. Similar impacts on infection probability. This is important because it impacts the future effectiveness of some of our interventions, such as Wolbachia. How long are the mosquitoes going to live for, and how well does Wolbachia survive in these mosquitoes in the face of increasing temperatures? There is some evidence that W-MEL strain does lose effectiveness at a higher heat, and in particular exposure to transient kind of shocks to high temperatures, but high being on the order of 36 to 38 degrees Celsius, which is not unheard of in a lot of parts of the world right now. The strain WLB is showing more promise in terms of being heat tolerant, but it itself is also not climate proof. So as we go forward and plan for our interventions in the face of climate change, they're going to have to be heat tolerant and planning for this. The impact of rainfall, as mentioned by Henrik, is complex. And local contact is very, very important. So there's evidence that obviously increased rainfall can increase your breeding sites by having standing water collecting in trash, leaves, coconut shells, plastic, or increased rainfall may flush out larval habitats. So with enough rain, you flush out the larvae and a breeding site is no longer a breeding site. So these are kind of complex interactions. And there's also clear evidence that drought can increase the risk of dengue. And an example that's particularly poignant, going back to 2015 in Brazil, was the instance of Sao Paulo, where there was a significant drought occurring in the context of dramatic population growth in both Sao Paulo and Rio de Janeiro, but especially Sao Paulo, resulting in people storing water out of necessity in the face of this drought, which resulted in breeding sites, overwhelming dengue transmission a few months after the drought, an overwhelmed healthcare system with a dramatic outbreak in 2015 in Sao Paulo, shown there in orange, compared to the year prior, shown in yellow. We and others in our work in Thailand, but this is also supported in work in Kenya and also touched upon by Dr. Shirin in her work in Bangladesh, plastic is a problem. And this is perhaps somewhat obvious, but this is a non-degradable breeding source. Our work and other work has suggested that plastic can be up to 40% of breeding sites identified, productive breeding sites, and the burden of plastic is just increasing exponentially across the globe, so creating increasing breeding sites. And the distribution of this risk is not uniform. This is going to be a theme throughout my slides and my talk, is that the risk of dengue is not uniform and it's experienced differently by people even in the same regions. So in our Thai cohort study, these are pictures from Kampeng Phet with a rural site shown on the left and our semi-urban site shown on the right. These are very different environments. I think the risk factors for dengue exposure are quite different, but notably we saw that the rural areas there on the left did not have trash infrastructure, they had a much higher burden of plastic, and they had a higher burden of dengue seropositivity, suggesting that infrastructure, access to trash management, for example, and plastic waste are important. This is one of my favorite examples historically of the importance of infrastructure as a kind of non-sexy but very, very important means of protecting vulnerable communities against dengue. So in 2005, there was an outbreak on the US-Mexico border in Matamoros on the Mexico side and Brownsville on the US side, and the infection rates were noticeably different. Investigators went in and they looked at what are the different protective or risk factors associated between the two sites. And somewhat intuitively, but powerfully, I think, it came down largely to socioeconomics and infrastructure. So on the Mexico side, people were more likely to not have reliable access to water. They didn't have screens on their windows. They did not have air conditioning. They had lower household incomes. And these data have been replicated in other studies, including in ours. Screened doors are very important. Again, not sexy, but impactful. So this suggests that socioeconomics and infrastructure are critical, and they impact the current and future risks of dengue. And again, they impact different populations disproportionately. This is a schematic that I put together, but it's comparing the amount spent per year in US billions of dollars on dengue vaccines and infrastructure, contrasted against estimated reductions in transmission. So we've had some great progress in dengue vaccines, and dengue vaccines will no doubt be a very important cornerstone of dengue control going forward. I should have also added Wolbachia and other very promising advances in vector control to this. On average, it's estimated that low middle income countries spend about $50 million per year on infrastructure, but they have a higher impact on reducing transmission. And this is not just for dengue, but also for chikungunya, a wide variety of other wash pathogens as we increase access to piped water, to sanitation, to hygiene. So this is something that we need to be thinking about as we put all this together. And it's hard because nobody wants to fund infrastructure. I can't imagine writing an NIH grant where I'm proposing that I study infrastructure or how I would even do that. But it's important and it needs to be in the mix here as we think about it. This also came up previously in Dr. Waitumbi's talk when he was mentioning that there was an outbreak of dengue in a refugee camp in Kenya. That has been well documented. And it is a problem that is only going to grow as we look forward to 2075. So the map on the top is data from UNHCR showing with the size of the circle representing the size of the population, but the density map of where displaced persons come from by their country of origin. And you can see that overlaps a lot with dengue endemic parts of the world, tropical and subtropical regions of the world. It's estimated by 2050 up to 1.2 billion people will be displaced by climate and conflict, with millions already displaced every year. And the data are clear that these displaced people, because of poorer access to water, sanitation, and hygiene, poorer nutrition, poor access to healthcare, are at high risk for dengue, and this is already borne out. Looking forward to some of the environmental changes we may expect to see. So urbanization has obviously already been happening for decades, but will continue to happen, here projecting out to 2100, again with some concentration in some tropical and subtropical regions of the world that are already endemic for dengue, increasing the transmission risk. But perhaps the highest risk is going to be unplanned urbanization, so increasing density of people in the absence of reliable infrastructure. This is a common theme. Additionally, you may see popping up of, as we are already seeing, developments and people clustering together on the borders of forests, coming into more contact with possibly sylvatic dengue or other Zika to come. So this is really potentially the perfect storm going forward in the next few decades, is urbanization in the absence of reliable infrastructure, placing people more in contact with sylvatic threats. So what flavivirus will come next? And this is a little tongue-in-cheek, but a concern is we already have a hard enough time creating a vaccine that protects against all 4 dengue serotypes durably in seronegative people. And now with increased evidence that possibly there is some interaction between dengue and Zika that has clinical outcomes, we're thinking a bit about, do we need to be vaccinating for dengue and Zika at the same time? Is this placing us increasingly in an impossible vaccine development challenge? And then what about the next flavivirus to come? So in the coming decades, we are going to really have to develop the tools that we need to identify which virus causes which disease, which interactions are important, or even more optimally, can we develop vaccines that give us broad protection, and to understand those correlates of protection. Henrik spoke a bit about the changing demography of populations with declining birth rates. A parallel trend is that people are living longer. So this is a trend just showing life expectancy from 1950 to 2023. So it continues to go up, thankfully. But it raises the question, there's already some evidence that potentially dengue reinfection occurs, challenging some of our long-held dogma. So as people get older and older, is their protection truly going to be lifelong? Especially when placed in the context of things like immunosenescence, or in places like Thailand where you may be exposed to dengue many times, dozens of times in your lifetime. How does your immune response update? How does your immune reserve to fight against dengue remain in place, particularly in the context of increasing exposure to new genotypes, divergent strains, this global mixing of people and viruses? So how will this hold up? Do we have to worry about geriatric dengue globally and not just in Brazil, as we were hearing about today? Touching briefly on something that Henrik had mentioned already is, could our tools from today create tomorrow's outbreaks? And I don't think that we would take, I'm going to say again, kind of tongue-in-cheek, the initial Sweden approach to COVID, where let's just let this run amok. We should be doing all of the integrated countermeasures as we can, but all of them will be leaky. And so as we introduce these interventions, but dengue still circulates, we'll have more individuals exposed outside of this temporary window of cross protection, potentially resulting in more disease overall. And we'll probably see increased disease in adults, which will present differently and present new challenges for how we manage. We may see less plasma leakage as something that we think is more of a pathophysiological phenomenon in children. On the other hand, we may see more bleeding and clotting disorders. How are we going to manage fluids in these more complex comorbid populations? And this is, I'll just touch on this briefly, but I really like these figures a lot. This is another applied example. Henrik had showed increasing age of dengue in Thailand. Here we're looking at the increasing age of dengue in Singapore after very successful vector control interventions. In the left figure, we're seeing in 1960 a very impressive reduction in Aedes aegypti household index, driven by very aggressive governmental focus on vector control. But then they began to see increasing clinical incidence of dengue fever, And then on the right, you see increasing cases in adults. So this has already been borne out in multiple populations in multiple instances. The other thing we may need to look forward to is it is unlikely, but maybe not impossible, but it's been challenging to date to generate vaccines that create balanced immunity to all 4 serotypes. And looking at pneumococcal vaccines as a possible example, we need to look forward to possible serotype replacement. So what we're looking at here is this is data from PCV, pneumococcal vaccine in New Zealand, where they had multiple different iterations of pneumococcal vaccines, some of which contain obviously different serotypes than others. And of interest in New Zealand was the emergence of 19A, which was not present in any of the other vaccines besides PCV13. And as they went through different iterations, you can see going on in time this dramatic emergent and replacement of 19A, which was associated with increased clinical disease. This is also important because I recognize that the context for different serotype circulation globally is different. But I will say that in Thailand, the data are very clear that all 4 serotypes have the potential to cause significant disease. So it's not, based upon our experience and our data, we can't say any of them are not important and not look out for this. Looking forward, it'll be interesting to hypothesize and see what happens with the future of Latin America, as already touched upon today, with interesting being an understatement, obviously. But comparing Nicaragua and Brazil, we see similar trends in terms of an increasing incidence, historical patterns to varying degrees of a dominance of one serotype over another, with Brazil having very clear, at least in this instance, sequential introduction of different serotypes. And that's different than what the situation has been in Thailand, we believe, for decades now, where there's year to year all 4 serotypes in circulation, and this is just data from Kampeng Phet, so a certain region, with a relatively high burden of infection and force of infection every year, and again, all 4 serotypes present. So it stands to question and explore what may happen for the future of Zika, for the future of yellow fever, as Brazil, as Nicaragua possibly develop these more complex immune profiles in the setting of increasing exposure to different serotypes. As we go forward to 2075, we will need to have a more systematic approach to how we are responding. The current responsive approach in many areas, which I can appreciate as someone who practices local public health here, is that you find a case of something, you go to that home, and you spray. The mosquitoes may or may not be resistant. So this is the norm, but it's somewhat low yield. What if, going forward, we had homes that had improved infrastructure proactively, we had a better understanding of community hotspots and the populations who bring dengue virus between these locations. We then have an understanding of where we can best target our interventions, both vaccines as well as vector control, possibly not just targeting children or the individuals with the highest burden of disease, but possibly also these bridge populations, like is done for influenza, to protect others. And all of this in a backdrop of proactive environmental and clinical surveillance, so possibly wastewater, which is the toilet icon on the left, and increased clinical surveillance across broad regions. So going forward, we really need to have an integrated systems toolkit that has not just vaccines, which are critical, vector control, which is critical, and increased WASH infrastructure, but also surveillance, with regions having more ownership and access to surveillance so that they can benefit from these opportunities for interventions going forward. So they can benefit from Wolbachia, from these vaccines that require monitoring for virologically confirmed disease. We need climate-adapted, evidence-based vector control, balanced vaccines, implementation science, which is, I think it came up very nicely in the prior discussion from Brazil, that vaccines do not equal vaccinations. So we can have the best tool in the world, but if we can't get it in the arms of people who need it and complete the dose for safety as well as efficacy, we're not going to make much progress. And increasingly, as we can, and as we set up the systems to do this, to be thinking about how do we protect against not just dengue, but chikungunya and diarrheal disease. And again, this comes back to non-sexy things like infrastructure. This opens up a wide variety of interesting research questions, aging adults, how climate is regionally dependent and infrastructure dependent, the complexity of these different flaviviruses and the flaviviruses to come. How can we get to a single-dose vaccine? I know that there are some coming up, and that's very promising. Targeting our countermeasures, and then importantly, implementation science. And I think we want to be certain that we're not funding what worked in 1975 for what we need to work in 2075. I'm going to touch very briefly, and I know I'm running out of time, but just to go through some examples of vaccines not equaling vaccinations and where a global approach falls apart. So these are data from COVID, and I'll go over it relatively quickly, but as we all saw in COVID globally, the system fell apart. Global coordination failed. For a wide variety of reasons, but highlighted nicely on these graphs in the New York Times, we can see that as of March 2021, the top right graph is proportion of the population that was vaccinated, and then the right was GDP per capita. So richer countries were more vaccinated, and in the lower graph, the richer countries were vaccinated sooner. This is my second to last slide, but a local example is with Mpox. So again, I work in the county health department. Mpox began to emerge in our population in 2022, 2023. We had access to more vaccine than you can even imagine and had a difficult time, despite all of our proactive outreach, getting it into the arms of people who really needed it for a wide variety of reasons: trust, access, how do we find them, how do we message to them. And then last year, when there was this dramatic outbreak of a more virulent strain with children dying in Nigeria, we again had more vaccine than we could use and couldn't get it into the arms of people who need it. And so this is showing the imbalance between Mpox vaccine available to the United States and Mpox available to Africa, again, in the face of a very severe fatal outbreak. So in closing, our challenge for 2075 is that our threat is accelerating, but our interventions are only going to succeed when they're matched to local realities and they actually go from vaccines to vaccinations, for example. And we need to reassess what has been the status quo and also the siloing of these different strategies. The last thing I'll say is, in putting this together, it was a little bit overwhelming to think about how we, sitting in this room, could develop global equity strategies for distribution of vaccines infrastructure. But there are things that we can do in our research to start to build up the resources and the capabilities at our partner sites in LMIC countries, for example. And that's making sure that we are co-partnering with them, that we are building up capacity, and that we are engaging with communities to measure and work on the work that is actually going to move the needle in the communities that we're working in. So this work is what's going to actually help drive whether dengue is controlled in 2075 or not. Thank you.